everyone. Thank you all so much for joining. I hope you guys can hear me. Throughout this chat, I'm going to be using the chat function. I hope I have my chat screen open. I hope it's not blocking the screen. Someone please let me know if it is. But anyway, we're probably going to start in about 1 or 2 minutes. I just want to see if anybody trickles in right after the hour. But I'll start with a brief introduction. My name is Jackie. I'm a fourth-year medical student down in Florida. My passion is cardiology and cardiac surgery, so I'm really excited to be giving this talk to you guys today, where we're going to talk about congenital heart defects, which is a subtopic of pediatrics. So wondering if we have some people interested in peds, maybe some people interested in heart stuff. Let me know in the chat. I'd love to talk to you guys about it. Like I said, we're going to be using the chat function during this discussion. I'm never going to cold call anyone in the participants list, but I will be asking a lot of questions to you guys during the talk. So feel free to unmute and talk. But if that feels too aggressive, then please just put your answers into the chat, or you can just directly message me if you don't want to share your thoughts with the group. But I think it's great. It's a great way for everyone to learn if you can share with everyone. So anyway, we're going to get started. Here we go. Please stop me as we're going. If anything I say is confusing, we're just going to get started. Oops. All right, so session outline for those of you who haven't been to a virtual rounds before, we're going to start with the case, go through the physical exam, go through some differentials, assessment and plan, and then we're going to talk about pathophysiology a little bit. As I said before, you're encouraged to actively participate. I'm never going to call on you guys, but I would love to start a discussion in the chat if you guys want to do that. But like I said, if you don't want to message in the chat publicly, feel free to just message me directly, and I'll address your question anonymously to the group. So we're going to start with the SOAP note. I'm not sure. I don't recognize a lot of these names here. So for some people, this might be your first virtual rounds. And if that's the case, I just like to go through quickly what the SOAP note is, because I think it's confusing to a lot of people. For those of you who are pursuing medical school in the future, learning how to write a good SOAP note is something that you're going to use. I've used this during my rotations. I've seen a lot of the residents I work with using it. So it's a great skill to develop now. So can anyone tell me what would go in the subjective portion of your SOAP note? Not just reading off of the form, but what types of things? Sorry?
Yes, that would be anything you observe from the patient just by looking at them or from doing test results.
Okay, so that's a great start. So subjective is going to be anything coming from the patient. So as you said, anything that they say to you, Emily, you're exactly right. Anything they say. So are you, Adrika? Things that they say to you. Sorry, is someone talking?
No, sorry.
Oh, no, it's okay. So it's anything that they say to you versus the objective section is going to be then what? How does that make it different than subjective?
Objective is different because that's what you observe or anything you learn from doing exams that you conduct on the patient.
Yes, that's exactly right. So objective is going to be vital signs, physical exam findings. If we were to run labs or do imaging, those types of things would be objective because they're just true things. Subjective, not to say that all patients lie, but sometimes people kind of don't tell, maybe the way they're describing their symptoms isn't exactly correct technically. So that's anything that they say to you that kind of we're withholding judgment on if it's a fact or if it's just an opinion. And then objective is like your creatinine is 5. And so that would be really high, but it's something like that. And then assessment and plan we're going to develop together. And that's going to be dependent upon the patient. So I hope that makes sense. It helps if you guys fill that in. Participants can now see your application. I don't know what that means. So it's, I just lost my train of thought. Oh, it's helpful if you fill it out as we go. So if you want me to stop, pause, go back to a slide, I'm happy to do that. Usually I do that at the end too, if you guys need to fill stuff out. So I hope that clears that up. We're going to jump right into the case. All right, so here's our patient. His name is Parker Trench. He is a 3-year-old boy who was brought to the emergency department by his mother due to increasing shortness of breath for the past 2 days. He's at the 25th percentile for both height and weight and was born at 38 weeks gestation with no complications. So where would this go in our SOAP note, this information?
Objective.
Subjective, that's exactly right. So this is going to be part of our, we call it the HPI, or the history of present illness. Perfect. When someone's done, just give me a thumbs up, or don't give a thumbs up on your screen because I can't see you. But if you could just say like done or something in the chat, so that way I don't move too quickly. Done. Adrika, you're a speed demon. Let's keep going. So that was Parker. And now we have the mom with us. So what else do we want to ask her? And I'll answer as if I'm the mom.
How long has he had this difficulty breathing, and when did it start? If you can recall.
Yeah, so it's been kind of progressive over the past week or so, but it's been getting worse. He's had it for.
Okay.
Okay. So Adrika's asking, were there any activities that set the shortness of breath off? That's a great question. So I think you're trying to ask, maybe was he running around, something like that. It's definitely worse. He hasn't been running around as much as he usually does. He's been a little bit more sedentary, sitting down a lot more for about the past month. Marlena is asking, does he have any allergies? Great question. No, he doesn't have any allergies that we know of. And no one else in the house is sick. It's just me, his dad, and him, and no one else has been sick. But those are great, great questions. What are you pointing at with those questions, Marlena? Emily's asking, how's his appetite been? That's a great question too. His appetite's been a little less. I would say he hasn't been eating as much. And does he have any other symptoms such as fatigue? Yeah, Brooke, that's a great question. He's been a little bit fatigued. He's been tired recently. So as you guys are asking these questions, are you thinking of any specific diagnoses? Are you starting to, I know that this presentation has a topic, but we're we're suspending that for a moment. What are you asking these questions with in mind?
I think she's asking because I think these could also be the result of an allergy, or maybe if he's lethargic, this might be a sign of a heart issue, since heart issues usually go along with trouble breathing and lethargy.
That's a great point. That's an excellent point. So I definitely love that you guys asked about what activities are exacerbating it, maybe running. I love that you asked if he's sick. Adam is bringing up RSV, which is a very, very, very common kind of upper respiratory illness in children around the age of 2. So that's a great question to ask. Maybe if anyone else has been sick, as it's highly contagious, and maybe if he's been coughing or something like that related to RSV, Adam. Marlene is asking again, trying to think of a difference between anaphylaxis or viral illness. Those are both great because those can both lead to cough or kind of those upper respiratory symptoms. Anaphylaxis would definitely be a little more acute, but it's a great thing to keep on the differential. So we'll move forward. Here's a little bit of extra history about him. And you guys actually asked some really important questions that aren't even in this history, like when did it start? So birth history, he was born at 38 weeks, which is basically full term, to a 26-year-old prima gravida mother, which means it's her first child, with no complications. She received all routine prenatal care, including vaccinations, and didn't drink alcohol, smoke, or use illicit drugs during pregnancy. And his pregnancy birth weight was a little low, and he went home 2 days after his birth. So what's important there? Why are all of those statements important? What am I trying to point at?
I think those statements are important because if you know she didn't smoke or drink, you know, he likely doesn't have any birth defects from that, because those could usually cause birth defects. He's not premature, so he likely has good organ development. So maybe it's not an issue with the development of his organs.
No, so, these are all excellent points. Great job.
Thank you. I guess the birth weight kind of concerns me, but not really, because he wasn't premature. So it's fine there.
No, excellent points. So like you're saying, we call those teratogens, or things that can affect kind of developing fetuses as they're growing. So you're right. She'd be a lot less likely to have any birth defects. All of the vaccines are important because there are certain types of infections that pregnant women can get that cause very specific syndromes in babies. So it's important that the mom had all of her routine vaccinations as a child and received care and was screened with ultrasounds. This isn't a pregnancy lecture, so I'm not going to get into it, but basically exactly what you said, we're whittling it down, unlikely to have really large birth defects. Birth weight's a little low. Baby is like a week or two early-ish, kind of right on the border. So it's a little low, but as you said, we're not super concerned with it yet. He went home 2 days later, so he's pretty much healthy. Not on any medications. So maybe he didn't have asthma as a young child because he might be on something for that. Family history, mom's got hypertension, and his paternal uncle had a heart surgery and died from complications at the age of 50. So again, which part of the SOAP note is all of this going in?
There would probably be family history.
Family history, right. Broadly, it will go into subjective, but usually within subjective, we'll put like family. Yes, Fawaz, you're right. It will go in subjective. We have not moved into objective yet. I don't know why this kid in the picture is playing with toothpaste, but he's well enough to play with toothpaste. All right, so we're going to move into the physical exam now. So this is now our objective. So on exam, he's in moderate distress. He's not cyanotic. What does cyanotic mean? Anyone?
Yes, he's having difficulty breathing, and that's causing his extremities to look blue.
Right. So cyanosis, cyan means blue. So kind of he's not blue anywhere around his mouth or in his fingers or toes. So he's perfusing well. He's getting blood. Vital signs. I just want to make a note here. If you're ever examining a child and their heart rate is high, does anyone know what the normal adult heart rate range is?
I think 120/80.
That's the blood pressure, and that's correct. That's average blood pressure for an adult. Yes, you are all correct, Seema, Marlena. It is 60 to 100 is correct for adults. So you might look at this kid's heart rate and be like, whoa, that's really high. And it is a little high, but for a young child, it's permissible for it to be higher. We're not going to get into exactly what the ranges are, but it is permissible for it to be higher, and it's not necessarily too high. His BP, though, is a little low. We don't expect it to be that low for children. So those are how's his temperature? Does he have a fever? No, yeah, he doesn't have a fever. A fever is 100.4 by definition. So he's not febrile. We would say he's a little tachycardic. He's breathing quite fast. Normal respirations, it's a little higher in kids, but in adults, it's about 16. So he's breathing quite quickly, and his blood pressure is a little low. His cardiac exam shows, this is the most important part, grade 3 out of 6, hollow systolic murmur at the base over the left lower sternal border, and a grade 1 out of 6 mid-diastolic murmur at the apex. So I'm going to break this down because I'm not expecting anyone here to know what all of this jumble means. So we grade murmurs. Does anyone know what causes murmurs, first of all?
Yes, a murmur is like a small hole in your heart. And so that means it allows blood to flow a bit quicker through your heart than it normally would.
Okay, so murmurs can be caused by holes in the heart, but broadly speaking, murmurs are caused by abnormal flow. Rubbing of the heart wall, that can cause sounds for sure in things like pericarditis. Adam, you're right. In most cases, murmur is a valve issue. So we remember from physics that there's laminar flow, which is just straight flow like down a tube with no obstructions. And then you have turbulent flow, which is when kind of normal streams of blood or fluid hit something and then they form little kind of turbulence in the water. So that's what causes murmurs. When we hear murmurs, we're hearing abnormal flow that's not just going laminarly through the valves and the normal chambers of the heart. So first of all, when we're hearing a murmur, typically, like Adam is saying, that means that it's a valvular issue. So we're already thinking maybe a valve. There are 2 phases to the heart cycle. We know the heart goes lub-dub, so it will contract and it will relax. As a muscle, it will squeeze and it will relax. So squeezing is systole and relaxing is diastole. So basically we're hearing abnormal flow as the heart squeezes. Hollow systolic means through the entire squeezing process, we hear a murmur. And diastole means that as the heart is relaxing, we're also hearing a murmur. So basically we're hearing turbulent flow during squeezing and relaxing of the heart. I hope that makes sense broadly. We're going to move over to this picture of the abdomen. I hope you guys can see my mouse. We're moving over to this picture of the thorax here. So it's over the left sternal border. So that's going to be, this is the sternum here. So it's here on the left sternal border. And this is the heart's apex. So we're hearing the murmur right around here, basically. So we're looking around some of these valves. Don't look at these dots to be where the valves actually are in the heart. Obviously, there's no valve just floating in the chest. This is just where the murmurs are loudest. So the tricuspid valve is not here. The tricuspid valve is up here. But so we're hearing a murmur right around this area of the heart, basically, during squeezing and relaxing. The respiratory exam shows bilateral crackles at the bases of the lungs. Does anyone know kind of what might be causing or what can cause sounds in the lungs? Certainly the lungs aren't supposed to be causing sounds like this. Fluid. Yeah, exactly. So this guy's got fluid in his lungs at the bases. We know that gravity likes to pull things down. So usually if we're hearing something at the bases, not so much at the tops, that means that gravity is pulling something down to the bases of the lungs, and typically that's going to be fluid. So, and we'll talk a little bit more about heart pathophysiology for how that all develops. And he's got no edema, meaning that his legs are not swollen, and he's, as we said, he's not cyanotic. Does anyone have any questions about any of these physical exam findings? No. All right. All right, so we do an X-ray. And does anyone know what this study is here on the right? An echo. Yeah, exactly. This is an echocardiogram. So let's start with this chest X-ray. I'm not expecting anyone here to be a radiologist, but does anybody want to make any comments about what we're seeing here on this chest X-ray?
Okay.
Enlarged heart. Adrika, you are right. Yeah, everyone's saying the heart seems big. That's a big heart. The heart should typically not be larger than half of the cavity. So if this is the entire cavity, this is way more than half. So this is a big heart. And lots of things can make the heart big. So that's not necessarily diagnostic, but it's nice to see. Well, it's not nice for Parker, but it's nice for us to all see that the heart's big. And we're seeing some kind of fluffiness around here, which is usually fluid, as you guys said. So we're seeing a little fluid, big heart, greater than half of the cavity. And that's pretty much all else we're seeing here. Now, when we do the echocardiogram, because we heard that big murmur, so now we wanted to take a better look at the heart to see what is going on there. So we take basically an ultrasound of the heart, and we're seeing, does anyone know what we're seeing here? Or is this normal? Is this abnormal? Any thoughts? Again, I'm not expecting anyone here to be a cardiologist, but any thoughts about what we're seeing here? I'll tell you, this is the right ventricle, and this is the left ventricle, and this is the right atria.
I guess it seems like blood is pumping, though I have a feeling that one ventricle is putting more pressure than the other.
That's correct.
It seems like I think it's the right.
Okay, good. And Seema, you're exactly right. There's a hole between the two ventricles. So we're seeing blood flow here from the left ventricle into the right ventricle. We can't really see directionality here, but that's what we're seeing here. And Adam, you're also right, because the blood is actually gonna end up going back and forth between these chambers as the heart expands and contracts. So you're both right that there is an aberrant hole here between the two ventricles, and that's what we're seeing here. So this would be diagnostic for us. So now that we've seen all of this, we're gonna get into that. It's about to happen. So first of all, we've seen all of that, but let's go back and build a differential for Parker. So what do we want to put on his broad differential, thinking of all the things that could be causing this condition or his condition? He's kind of short of breath, big heart, congested lungs. We already talked about some of them. We talked about RSV. We talked about asthma. Anything else?
What about heart failure or cardiomyopathy?
Sure. Heart failure is a great one. Heart failure is a broad term. that could definitely apply in this patient. Lots of different heart conditions can what we call decompensate into heart failure, where the heart just fails to pump appropriately and perfuse the body. So definitely this patient can be decompensating into heart failure. Anything else? Septal defects. Adam, that's great. Which septum? If you don't mind me calling you out. You don't need to say which septum. That was kind of a difficult question. I'm not too sure. Yeah, no, it was a hard question. So we looked at the, I know, we looked at that picture of the heart in his echocardiogram. And so the septum in this particular, there's a couple septums in the heart. So as we know, there are 4 chambers between the heart. And I give a talk on cardiac physiology and how the pumps and the electrocardiac system works. So if you guys want to see that, I'm happy to give one of those talks in the future. But anyway, as the blood is pumping through the heart, sometimes it leaks between the chambers where it shouldn't, because we should have 4 distinctly walled off cavities. So there's a septum between the atria, which are those 2 chambers at the top. And there's a septum between the ventricles, which is called the intraventricular septum. And then there's the interatrial septum, which is between the atria and the ventricles respectively. And so we can have holes in those chambers that cause physiologic changes. So that's a great point. So here are some things that I had come up with as being part of our differential. So as far as cardiac causes, we have acyanotic congenital defects. Remember that Parker was not cyanotic. He was not turning blue. So there are cyanotic and acyanotic, and we'll talk about both. So he could have a congenital defect in the heart, meaning something that happened during his kind of developmental process. He could have something wrong with his valves. As someone mentioned, many murmurs are caused by valvulopathies, and so potentially it could be valvular. He could have a viral myocarditis, maybe just the muscle itself is inflamed and angry. He could have pericarditis, meaning that the sac that the heart sits in is inflamed itself. And you guys brought up a couple of these too, maybe RSV, maybe pneumonia, maybe asthma. And then I just want to always say, when we're making differentials, it's important to think outside of the system. I know I've focused us very early on the heart, but also if he had a hernia, meaning the organs are kind of displacing into places they shouldn't, if the diaphragm, which sits under the heart and lungs, had a hole in it, and some of those intestines went up into where the lungs should be, that can compress the lungs and that can cause shortness of breath as well. So things like that, it's important to keep your differential broad. Your attendings and residents will like you a lot more if you keep it broad. Any questions about this? Nope. Awesome. You guys have been doing a great job with this. So here is our assessment and plan. And if there's anything you guys want to add to this, you're more than welcome to. So we're going to do that echocardiogram. We've already done one. I showed it to you just for completeness sake, but we're going to do that echocardiogram. And so this patient has kind of a complicated diagnosis. So what he had was what we call a ventricular septal defect, which I think Adam was kind of hinting at earlier. So meaning that between the ventricles, that septum that's supposed to be separating those 2 bottom chambers has a hole in it. So blood is flowing from the left heart into the right heart when it shouldn't be. If that happens to an extreme, what can happen is the fluid, do the echo results go into the assessment and plan? No, just the echo, just to do the echo itself would go in the assessment and plan. We're going to keep following. You can say like follow up with echocardiograms. So when the blood keeps flowing between the chambers when it shouldn't through that hole, it can actually overload the lungs. And the lungs can become so high pressure, as was happening with him. His lungs got really congested with fluid, as you guys said. And if the lungs get too congested with fluid, they can create back pressure on the heart. And that can cause a phenomenon called Eisenmenger syndrome. Oh, there should be a G there, Eisenmenger. No, there is a G there, Eisenmenger. I feel like I'm having a stroke, I'm sorry. It can back up and cause basically heart failure because the lungs have developed high pressure, and then that high pressure puts pressure back on the heart. It's a very complicated syndrome, but I thought it was nice to talk about because it brings up a lot of pathophysiology points for the heart. So in that echocardiogram, we're going to look at how big is that septal defect? Where is it in the septum? How congested is the heart? How congested are the lungs? And then we're going to refer him to pediatric cardiology just to follow him to see what we need to do about the septal defect. Do we need to repair it? Can we just monitor him and whatnot? So this is our assessment and plan. It's pretty bare bones. Yeah, any questions about this? Nope, awesome. Okay, so we're going to talk about heart embryology for just a moment. Because we're talking about pediatrics, we have to talk about where the kids are coming from. So the heart basically is a giant tube, as you can see here. The heart, as it develops, forms this big tube with the 4 in/outflow tracts, and then it kind of twists upon itself and forms this little ball thing. So as it's forming this ball, that's when all of the different septum will form, as we were talking about before. Here are the 2 atria, which sit on top, and here are the 2 ventricles, which sit on the bottom. So between the 2 atria forms the atrial septum, and between the ventricles forms the interventricular septum. So as you can imagine, if these septums don't form appropriately, then we can have blood flowing between these two. And as the heart beats, it's going to be pushing blood into chambers where it shouldn't be going. So that's kind of broadly how a lot of these defects can develop. And there are other types of defects where this tube doesn't twist properly or this tube doesn't separate properly, but we won't get into that because those get a little bit sticky. So we're going to talk briefly about heart anatomy because I think it's important to kind of understand where all of this is coming from. So let's start by seeing where you guys' knowledge is. So if this is the lung, does someone want to describe to me how blood flows from the lungs, oxygenated blood flows from the lungs and into the body? What structures will it traverse?
I can do it. So for oxygenated blood from the lungs will go through the pulmonary vein into the left atrium, and then from there it goes into the left ventricle and then out through the aorta. Perfect.
And in that process, it will cross the mitral valve, and then that's how oxygenated blood will get into the body. Absolutely perfect. So this is called the left side of the heart. The left side of the heart is the oxygenated side of the heart. This is the money side because this is where the heart's going to do its main job, which is to pump blood out. And so who wants to now do blood coming back into the heart? So now the blood's gone out into all of the tissues. It's going to discharge its oxygen onto those tissues, and then the deoxygenated blood's going to come back into the right heart. So who wants to do that flow?
I can go again if no one else wants to.
Go for it.
Yeah, so it will come in through the superior and inferior vena cava, and then it'll go into the right atrium, to the right ventricle, and then to the lungs, to the pulmonary artery.
Perfect. Thank you. And thank you, Fawaz, as well. So you guys are both exactly right. Adam, you are right as well. Nice job, guys. So I just want to make that clear. I know it might seem a little dumb because we have the picture right here, but as we talk about kind of how the pressures change, I think it's important to just lay down some bare bones. So this is the right side of the heart. Does anyone have a theory about which side of the heart is going to be higher pressure, the left side or the right side? Left. Oh, sorry. Yeah, it's the left side of the heart. So everybody here is right. So the left side is going to be the higher pressure side because that's, we're trying to pump the blood out from this side. This side's going to be a little bit, think about just arteries are higher pressure in general than veins. A good trick is if you can compress it easily, then it's a vein. And if you can't, then it's an artery. So this is always the higher pressure side of the heart. So now that we've kind of cleared that up, we can start talking about how some of these defects occur. So let's talk briefly about the two different types of congenital heart defects that we can have. We can have cyanotic and we can have acyanotic. And we talked briefly about how cyanosis means blue, kind of deoxygenated broadly in the body. And so these cyanotic heart defects are going to be what we call right to left, meaning that deoxygenated blood from the right side of the heart is going into the systemic circulation. And here are some examples of some of those. Versus the acyanotic ones are going to be left to right, meaning that oxygenated blood is now flowing into the right side of the system. Now, I know this is a confusing concept, so I'm going to actually go back if I can. Just kidding. What's this? No, we're going to go back to here and we're going to talk about it again. So I said that for the congenital heart defects that are cyanotic, we have right-sided blood going into the left-sided circulation. So I want you guys to imagine that in this diagram, imagine that the pulmonary artery and the aorta have switched places. So now this valve is here and this valve is here. Now, does someone want to talk through in this condition that we call transposition of the great vessels, which is a cyanotic heart disease, what structures oxygenated blood would go through coming from the lungs? Let's see. Pulmonary artery. Yeah, exactly. So it's going to come in through the pulmonary vein, left atria, left ventricle, and then basically back into the lungs. And then on the other side, we would have deoxygenated blood coming back from the body and then coming through the right atria. And then this deoxygenated blood is going to go up into the aorta and go back out into the body. So we call this a right to left shunt because we have right-sided blood here, which is deoxygenated, going out into the systemic circulation, which is the left side of the heart. I'm not sure if that is completely clear, but it's basically when I say right to left, I'm meaning deoxygenated blood is going into where the oxygenated blood is meant to be. Makes sense. Awesome. And this is now so that's an example. Transposition of the great arteries is when these two switch places, and that's a great example of a cyanotic heart disease. So this baby is going to look very, very sick. So our patient Parker was 3 years old presenting with this, but our cyanotic heart babies are going to be days, maybe hours old. They're going to be blue around the mouth. They're going to be breathing super fast. They're going to be extremely sick from a very early age, for the most part. And so that's another big difference here. Now for our acyanotic heart diseases, these are left to right shunts now. Are these babies what we call blue babies? Yeah, Adrika, you're exactly right. We call these blue babies in general. These cyanotic heart disease babies are typically blue. A lot of those times they're talking about a specific type of cyanotic heart babies called tetralogy of Fallot babies or TET babies. But yes, those are definitely the ones who are blue. So now we move into the acyanotic heart diseases, which are the babies who have left to right shunting. So we talked about that the left side of the heart is higher pressure. So if we had a hole here in the heart, in the case of our patient who had a VSD. So what we're seeing now is blood is coming from the lungs into the left atria, into the left ventricle. And then when the heart squeezes here from the bottom and squeezes up to try to push blood out into the systemic circulation, some of the blood will go up, but some of the blood will also go here to the right because things always want to move into the lower pressure system. So we're going to basically lose some of our oxygenated blood that's meant to be shooting out into the systemic circulation. Some of that blood's accidentally going to go this way. So we're going to get oxygenated blood now going left to right, which is going to end up feeding back into the lungs. So it's just going to be reoxygenated again, basically. So these diseases, VSDs are extremely common. I think it's like 4 to 5% of babies have VSDs when they're born, and many actually close spontaneously. So many of them are not even going to need treatment. I know one of my classmates in medical school had a VSD as a baby that was never fixed, and now he's fine. So these happen very commonly. We talked about with this mother how she had no drinking, no smoking, no had all of her childhood vaccinations. So she was at lower risk of developing any of these congenital heart defects. Had she been a poorly controlled diabetic, had she had any number of pregnant kind of peri-pregnancy illnesses, she might have developed some of these cyanotic heart diseases, having one of these blue babies that we're talking about. But VSDs on their own can arise sometimes from fetal alcohol syndrome, but they can also just happen spontaneously. So as you can see here, if this hole is quite small, we're not going to be losing that much blood that should be being pumped out. And therefore, this patient's not going to be terribly symptomatic. Now, in our patient, this hole might be a little bit bigger. And so that's why he's becoming symptomatic. So I mentioned in the assessment and plan that this patient was developing Eisenmenger syndrome. So now we're going to talk about kind of what Eisenmenger syndrome is now that we've got kind of the base laid down. So Eisenmenger, again, is where too much blood is spilling out here through the hole, the VSD, and is going into the lungs. So what happens is the lungs are getting more blood to them than they should be getting, because they're getting the blood coming in from the right-sided circulation, plus this extra blood that's coming from the left heart. So the lungs are kind of overworking themselves to try to process this much fluid. As a result, they become kind of fluid overloaded. As you saw, Parker's got fluid at the bottom of his lungs. He's got some edema down there. And so because these lungs are overloaded, they're going to get kind of exhausted. They're not going to be able to kind of push that oxygenated blood out as effectively because they're getting so congested. And so what ends up happening is they're not pushing blood appropriately back to the heart because they're so congested. So we become kind of backed up here as well because this side is not getting enough blood. And we kind of get this heart failure type picture because the lungs have become so congested that they now can't do their job, which now affects the left heart. But the left heart is what's affecting the right heart because of the hole. And it just becomes this awful cycle where basically his heart disease caused a lung disease, which is now negatively affecting the heart again. So that's Eisenmenger syndrome. When you have one of these, what should be not too terribly severe heart conditions, these acyanotic heart conditions that end up overloading the lungs that then negatively affects the heart. So that's what this patient had. I hope that makes some sense. I know that it's a little confusing. Any questions about Eisenmenger syndrome or VSDs? Nope. Awesome. All right, so here are some pictures, which I think are kind of cool. So as I said, many of the times these defects do not need to be fixed and they do not need to be closed because they close on their own. But if they're quite large, potentially in this case, we might put in a patch here. So here they're parachuting down a patch to close a VSD. And so this is what the closed VSD patch is going to look like. They can also go percutaneously and patch it here. If they were to go up the vein, and they can patch it this way. This is an open heart procedure, which they would probably do if he had bad veins or if his condition was quite severe and they didn't have a patch that was going to fit. So I think that's actually everything I have for you guys. So I'll take the rest of the time to answer any questions that you have about anything, about cardiology, about congenital heart defects, about cardiac surgery. As I said, I'm a fourth year medical student, so any questions you have about medical school as well. I'll just hang tight for the rest of the time to answer any questions that you have. Thank you guys so much for coming. Next week, I'm doing a session about basics of EKG reading. So if you want to learn the basics about how to approach an EKG and wow your friends and classmates, then show up next week. I hope to see some of you guys then. I think it'll be a lot of fun. But yeah, so I'll just hang by and see if you guys have any questions. No problem. You're welcome. Are cyanotic heart defects pretty much always found right at birth? Okay, so that's a great question, Marlena. So many cyanotic heart defects are so severe that we'll catch them usually right away. Usually we'll catch them at birth. Sometimes you can even catch them on ultrasound while the baby is still in utero. If they're severe enough, oftentimes we can catch them while the baby is there, because we'll realize the baby's not really growing appropriately. They're quite small. So then we can actually look at the developing fetal heart and be like, whoa, this kid is definitely going to need heart surgery. They've got some holes in their heart. So we often find them pretty early now because we've gotten so advanced, but there are some cases where, especially if people have lower levels of access to prenatal care and whatnot, where maybe these things are missed and then identified in early childhood. But for the most part, cyanotic heart defects are found very early, and acyanotic ones may never actually be caught, or they may be caught much later. Yeah, I think it's really interesting too. Pediatric cardiology is a really cool field for people who love cardiac anatomy. And actually the coolest cardiac surgeries are happening in pediatric cardiology because it's all of these, the veins and the arteries aren't in the right place, and it's pretty cool. Is anyone here interested in cardiology or pediatrics?
I am. It seems awesome.
Yeah.
The physical part.
It's a really cool field. It's a really cool field. I'll stop my sharing, but like I said, I'll hang tight if you guys have any questions. Sorry, this session ran a little quick. You guys answered my questions way faster than I was expecting.
It was nice meeting you, and have a nice night.
Thank you. You too. I hope to see you guys next week.
Of course. Thank you. Bye.
What aspect of cardio? Oh, I'm most interested in electrophysiology. So next week is really my jam, which is the EKGs and everything. I love the electrical conduction system of the heart. I came into medical school wanting to do heart surgery, and then I kind of pivoted to cardiology a few months ago, actually. So I think that I want to do kind of electrophysiology, pacemakers and stuff. But I also like the stents and for the heart attacks and stuff too. A lot of the valvular surgeries are now happening with cardiologists, not cardiac surgeons, actually. You often don't need open heart. So I think that's really cool. I think it's the future. Are you interested in cardiology as well? Yeah, it's the coolest field. I'm extremely biased, but I think it's the coolest field. I might be. It is. It's the one that it's the only one that makes sense to me, really. I might be staying in Florida for residency. I'm starting to put out my applications for residency actually in the next few months here. So we shall see where the match ends up taking me. Thank you. Yeah, I will definitely see you next week. Can't wait to talk about EKGs with you all. Thank you so much for coming and for participating.